Thank you so much. It is great to be here. Very good. It's a big microphone. I can promise I will shout. All right. We've heard a lot of discussion of working in common and sharing the money. I promise I won't talk about money. And we'll go back to things that regard valve physiology and what happens to the valve during the normal cardiac cycle. This is the mitral valve, and you recognize the big anterior leaflet, long but narrow, with a wide and short posterior leaflet. We see the primary cords that are attached to the border of the posterior leaflet. You could have sometimes a posterior leaflet that is longer than the usual and as long as the anterior leaflet. And here is the normal mitral valve seen from the atrial view, and you see the various scallops of the posterior leaflet, and you see in particular the position of the papillary muscle at the commissures and the multiple primary cords attached to the border of the leaflet and coming from the papillary muscle. The mitral annulus is here and is difficult to distinguish from that position. And this is the ventricular view. And the ventricular view shows the papillary muscle and the secondary cords attached to the valve much bigger. And this forms the mitral curtain. And that mitral curtain allows the blood to slide on the mitral valve during ejection. And this is shown here with the anterior leaflet covering the posterior leaflet. If 100,000 times a day the blood was hitting the valve directly, we would live very short lives because everybody would have mitral regurgitation. But the miracle of life, and if you believe in God, that's the time to believe in God, is that the blood slides on the mitral valve. And this is why this valve is much better than the valves that the NASA invents, because it can last more than 100 years, because the blood slides on the mitral valve instead of hitting it. And that's why you have a normal circulation. So the mitral valve, seen from the left atrium, has this segmentation. There are three scallops of the posterior leaflet that are called P1, P2, P3, and the regarding areas of the anterior leaflet are presented in front, A1, A2, A3. Now, the mitral annulus has much less attention paid to it, and the mitral annulus is here. And as you can see, it is like the root of a vegetable going inside the muscle and separating the atrial myocardium from the ventricular myocardium. The reason that we have a AV node is because there is a mitral annulus and there is electrical separation. Otherwise, we would be constantly having tons of extrasystole, irregular heart. You need a mitral annulus that is fibrous to separate the myocardium. And here we see that the mitral annulus is much stronger at the septal level than on the lateral level. There is much more root entering the myocardium than on the lateral side. In that microscopic view, you see again the separation from the left atrial myocardium and the ventricular myocardium because of the fibrous region of the annulus. And we see that annulus, but the mitral annulus has always been frustrating. When you do echo, which is the way that we're looking at the annulus, you see the 2 points, the posterior points, the anterior point of the annulus, but it's been very difficult to conceptualize what the annulus does. And so it's all frustrating, and the literature is very little. And at Mayo, Dr. Tsakiris, working with Earl Wood. Earl Wood is the guy who invented the G suit. You know, if we won Second World War, is because of this guy from Minnesota, because the pilots were passing out. And so Mayo paid for the research done to provide the American pilots with the G suit that allowed them not to pass out when they were turning. And Earl Wood is the guy that did the research that allowed to beat the Nazis. And And interestingly, I saw him early when I came to Mayo, and he was a very interesting person, very clever still when he was in his 90s. So that research was done with, markers on the mitral annulus of dogs, and the dogs were brought to the cineangiography and cinefluoroscopy, and what they saw at the time is that the annulus was changing in shape because of these markers in the frontal plane and in the lateral plane. And so they made a curve of that, and they showed that the annulus was dynamic. And so that dynamic annulus shows that there is a contraction in systole in normal dogs. So if you're a normal dog, I'm not sure that there is any dog here, you have a dynamic annulus. But what happened in humans? What do we know about human mitral annulus? Where there is Pravin Shah and his group that did that study, but if you look at the methods of the study, it's an interesting one. You see that the human mitral annulus is normally contracting, but what they were doing is putting a transducer on the chest of the patient and turning slowly, ignoring that the ribs were modifying the position of the transducer. The science behind this paper is kind of disputable and not very strong. And so even with TEE, it's frustrating because you see 2 points. But nevertheless, there was interesting research done by Bob Levine. He's an Israeli by heart, he showed that when you analyze by multiple views of the mitral annulus, you show that the mitral annulus has a saddle shape. You see, here is the saddle, the front of the saddle, the back of the saddle, and you're sitting in the middle, and that's the shape of the annulus that is the saddle shape. And so he was able to show that shape, and this has changed everything on how we evaluate mitral valve prolapse. You see here the diagnosis of prolapse is no difficulty, but when you look at the mitral valve prolapse in the four-chamber view, because of the saddle shape, you cannot make that diagnosis, and you have to look in long axis view to make the diagnosis of mitral valve prolapse. And you see the mitral valve prolapse here, and you see the annulus, but we have not a very good way, we did not have a very good way to look at the mitral annulus. And instead of looking at 2 points now, we can look at the pyramid of insonation of the mitral annulus, and we can look at the mitral valve through the ventricular view here, and we see the mitral valve complete and moving throughout the cardiac cycle on the ventricular view, and we can look at the mitral valve from the atrial side, and we see the mitral valve complete and moving throughout the cardiac cycle, and this view allows us to have a view of the mitral annulus. And so 3D is beautiful and is helping us making a diagnosis for these patients. And you see here a mitral valve that does not have a prolapse, a little nodule here. But what I'm asking you to look at is the mitral annulus on the border. You see the entire mitral annulus in one view, and this can be measured. Here is a patient with a flail posterior leaflet with a ruptured cord, and you can see the annulus. Here is the flail of the commissure, and you can see the annulus. Here is the flail with an extensive ballonization of the posterior leaflet, and you can see the mitral annulus. So that complete insonation of the mitral annulus changed the situation, and we were able to analyze the mitral valve. And the first result was presented by my colleague, Dr. Suri, who was a surgeon, because, there was a talk about the trigonal distance and how much we should put partial or complete rings when we correct MR. And we measured the circumference of the mitral annulus because of the software available for calculation, and we can put points everywhere on the annulus and have a representation of the circumference. And we see that the intertrigonal distance measured by the surgeon is identical to what is measured by echo or remeasured by echo, so we are accurate in our measurement. And when we look at patients with myxomatous disease, we can see that they have a higher circumference than normal patients, but the intertrigonal distance is respected, is not enlarged. What is enlarged in patients with myxomatous disease is the posterior annulus. So we do not need to put a circular ring. We can put a partial ring. And it is important to know that there is no necessity to put a complete ring. Now, the interesting part on the physiology of the annulus was to look at the dynamics of the annulus that had not been analyzed that way in humans. And we do multiple measurement of diameters, height, circumference, area. And here is represented an example of a mitral annulus in a normal subject in diastole and in systole. And you see the saddle here, and a myxomatous annulus in diastole and systole. And what we saw for the normal mitral annulus is very interesting. We divided the cardiac cycle in 6 parts, 3 diastole, 3 systole, and this is early systole that you see here, mid-systole and late systole. And the first thing that we see is that the diastole has no difference. For example, the AP diameter does not change in diastole, but in early systole, there is a contraction of the annulus, and we're going to see that. And that contraction of the annulus without intercommissural change leads to a small but significant change of the area. The area contracts, and so before the ventricle has completely contracted, that contraction of the annulus brings the posterior leaflet towards the anterior leaflet and approximates the 2 leaflets to avoid early systolic mitral regurgitation. Same thing with the saddle shape. Early in systole, there is a marked change in systole where the lateral parts of the annulus go down in the ventricle, approximating the leaflets. So if we did not have that early contraction, everybody in this room would have early systolic regurgitation. But if you do echoes, you see that early systolic regurgitation in normal subject is rare. And that is because of the annular contraction. And to understand that, we're going to see a sort of graph of that and how we can understand that annular function to prevent early regurgitation. So we see here the annulus, and so you see the mitral valve beating, and you see the movement. Yes, the annulus is dynamic, but we need to look slow. And in early systole, there is AP diameter contraction. It brings the posterior leaflet close to the anterior leaflet. And in early systole, there is saddle shape accentuation by descent of the lateral part of the annulus. And all these movements enhance the contact between the leaflet before the ventricle contracts and opposes the leaflets together. So we're going to look at these one by one. Diastole is here, and then still diastole, and we're in early systole here. The leaflets are not yet touching, so you have a potential for MR, but the contraction of the annulus here brings the posterior leaflet together with the anterior leaflet, and there is saddle shape accentuation, more marked here, and the 2 leaflets are now together. The valve is locked, and at the end of systole, the annulus relaxes itself, but this has no importance because the leaflets are locked. And then in diastole, the valve opens again. So the normal annulus is stable in diastole, and in early systole, there is AP contraction with area contraction and without intercommissural change, saddle shape accentuation. In late systole, the annulus relaxes, a saddle shape remains accentuated, and there is stretching because of that of the circumference, which is given back in early diastole. So what happens when you have myxomatous valve? When you have a myxomatous valve, the annulus is bigger. There is a little bit of AP diameter contraction, but interestingly, there is a lateral expansion in early systole, and so that there is no area contraction. So early in systole, the valves don't come together. And if you think about it, that dysfunction of the annulus is the only reason that there is early systolic regurgitation in patients with prolapse. The valve is not yet prolapsing. There should not be any MR. There is MR only because the annulus is dysfunctioning. In myxomatous disease, there is a specific myxomatous dysfunction of the annulus. The saddle shape does not accentuate, and that also contributes to the early MR of patients with mitral valve prolapse. So if we compare the two, yes, both are dynamic, but the annulus does not contract, and the only thing that happens is expansion in late systole. The annulus expands in late systole, and then this explains why there is not just the prolapse causing the MR, but the annular dysfunction, which separates further the leaflet and accentuates the MR caused by the prolapse. So once you see that, you understand that there is no saddle shape, no contraction, expansion laterally, and that separation of leaflet accentuates the MR. So what have we learned here? The myxomatous mitral annulus is weak contraction of the epidiameter without area contraction due to intercommissural dilatation, no saddle shape accentuation, and in late systole, the AP relaxes back to baseline. The shape slowly is accentuated, but there is marked enlargement of the annulus due to intercommissural enlargement that enhances the MR. And then we go back to diastole. So in early systole, no prevention of early MR, and in late systole, accentuation of the late mitral regurgitation. So every surgeon in the world is discussing how the MR, the annulus is dynamic and needs to be corrected, but the myxomatous annulus is dynamic, but dynamic all wrong. Everything that is dynamic here is wrong. So what is strange is that the ventricle, the normal ventricle and the mitral regurgitation ventricle contracts as well. Why is it that the annulus is dysfunctioning? And I'm going to give you a probable explanation, which is the mitral annular disjunction that we see histologically here and can be quite big. And I'm going to show you some. You see the annulus sliding on the muscle? The annulus does not slide normally on the muscle. And I'm going to show you more. This is a little annular disjunction. It slides on the annulus. That's a bigger one. You see how the muscle goes away from the annulus? And this is a big separation between the muscle and the annulus. The disjunction, because of the bad annular tissue between the annulus and the muscle, explains that you may have a ventricle that looks good, but it is not, the muscle is not moving the annulus. What happens post-op? You know, everybody says, oh, you need to have a physiologic annulus. It's very important. So here it is post-op. The surgeons, when they put the suture through the annulus to put the ring, correct the disjunction, and they eliminate the disjunction. But when you look at the circumference change throughout the cardiac cycle, in the myxomatous valve, the circumference expands instead of contracting, and after repair, it is smaller, but it still expands. If you put a band instead of a rigid ring, it is dynamic, but still dynamic wrong. And so it remains wrong afterward, but as we have restricted the annulus, the result is very stable over time. So what have we learned? We can look at the mitral annulus by 3D. Normal annular function prevents early systolic MR, and myxomatous annulus, despite being dynamic, is very dysfunctional. Now, MVP is also dynamic. We see here in that old M mode the dynamic MVP in late systole. And if you look at images, you see that MVP is dynamic, that it is occurring mostly in late systole. And you see that the MR of MVP is dynamic with a blast of color at end systole. So how dynamic? How dynamic is that? What does that mean clinically? And this is a paper that was done by a guy who is now an Israeli guy, Israeli cardiologist, when he was before he was Israeli cardiologist. And what it showed at the time is that rheumatic MR here and mitral valve prolapse with MR have a different pattern of timing of the MR. Late systolic here in the prolapse and holosystolic here. And you see with PISA that you see the dynamic nature of the MR in those patients. And in the old days, we showed that there was a dynamic nature of the PISA was increased over time, showing that the flow was increasing. But the velocity is also dynamic, changing throughout the cardiac cycle. So the force, the regurgitant force, changes throughout the cardiac cycle. And we have summarized here what happens. You know, everything changes, and the orifice of regurgitation progressively increases. So what that does is that it parallels the lesion progressively increasing. And the changes are kind of complex. In pink, here the squares are for the orifice, and that's the velocity. So you see that early to mid-late systole, the orifice increased, the velocity increased, the regurgitant volume increases markedly. But in late systole, the orifice increases markedly, but the velocity, the driving force decreases, so the regurgitant volume decreases. So the dynamics of the mitral regurgitation in mitral valve prolapse is complex, but we can measure, this correlation is the best. If you make a measurement at peak systole, you can make an accurate measurement of MR. So here for this example, the patient has dynamic MR, but we can prove that we can make an accurate measurement at the peak of the T wave, and it's the same regurgitant volume by Doppler and by PISA, so we can use PISA. So the dynamic change of MR are complex, and nevertheless we can make appropriate measurement. Now, the dynamic MR has another aspect, which is the continuous wave Doppler. We see the normal, we see the triangular when there is a big V wave, when patients have elevated left atrial pressure, but sometimes you see that, the end systolic MR, purely mid-late systolic MR. What do we do with this? What does that mean? Is mid-late systolic MR insignificant because most occurs late? Or is it very significant because we don't regurgitate during a part of systole? And this is a paper that we just published. That's an Israeli guy, too, here, that worked with me. Jan Topilsky worked with me 3 years, and he recently published this paper where we match patients with holosystolic MR to people with late systolic MR. And we quantified the MR. And what is interesting is that these are very misleading because the jet can be very large, the flow convergence can be very large, the orifice can be very large, but the regurgitant volume is smaller due to the fact that it's mid-late systolic MR.
Professor, we're going to wrap up now.
We're going to finish in 1 minute.
Thank you.
In 1 minute. And so there are less left atrial enlargement, less pressure, less volume enlargement. And what is interesting is that the outcome of the mid-late systolic MR is much more benign than the holosystolic MR. So these people, even though they look bad, the outcome is much simpler. So in this case, we need to use the regurgitant volume in those patients. And so what we have learned is that the dynamic, purely mid-late systolic MR is rarely severe, has a good outcome, and we don't need to rush, despite the appearance of the big jet, to correct those patients. Thank you very much for your attention.